Let me welcome all of you who are watching this 20-minute video because you have a clinical interest in lactose intolerance and lactose malabsorption. We will talk about clinical manifestations, we will talk about diagnosis and about its management. We first have to clarify terminology, definitions and symptoms of lactose intolerance. Lactose intolerance is a clinical syndrome in which ingestion of lactose or lactose-containing food causes symptoms of bloating, of flatulence, of abdominal pain, nausea, or diarrhea. Lactose intolerance may or may not be associated with lactose malabsorption, which is the failure of the small bowel to absorb ingested lactose due to lactase deficiency. The most common cause of primary lactose malabsorption is lactase deficiency due to enzyme non-persistence. And you have to observe that patients with lactose malabsorption may be asymptomatic. The high worldwide prevalence of primary lactase deficiency provides a large potential for carbohydrate intolerance. Have a look at this map of the world, where you see color coding of the proportion of the population with lactase deficiency in different countries of the world. There is the lowest proportion of patients with lactase deficiency in Denmark, here in green, 4%. The highest prevalence of lactase deficiency is in Korea, here in dark red, and other countries are also in the dark red. The reason for lactase deficiency, or the opposite of it, lactase persistence, is the genetic variation affecting lactase persistence. And in different regions of the world, different mutations have been identified which result in lactase persistence. As differential diagnosis, you have to be reminded of other causes of lactase deficiency, and this is the first congenital lactase deficiency, which is the absence of lactase activity in the small intestine with normal histologic findings and normal levels of other disaccharidases. This is a rare condition. It is autosomal recessive and mostly in Finnish populations. The children have diarrhea starting from birth, have hypercalcemia and nephrocalcinosis, and it is a very severe medical condition if milk is not replaced by other food. A second differential diagnosis is developmental lactase deficiency. And for this, you have to know that lactase activity in the fetus increases late in gestation. Therefore, premature infants born at 28 to 32 weeks of gestation have reduced lactase activity. If these infants are otherwise healthy, their colons can salvage the unabsorbed carbohydrates, preventing malnutrition and diarrhea. A third differential diagnosis of primary lactase deficiency is secondary lactase deficiency due to intestinal diseases that affect large areas of the mucosal surface and which result in a decrease of digestive capacity. These intestinal diseases may be infections, inflammation like inflammatory bowel disease, celiac disease, short bowel syndrome, or a small bowel damaged by radiation. The reason why lactose digestion is predominantly affected is due to its lower reserve capacities and due to its more distal location on the villus as compared with other disaccharidases. A fourth potential differential diagnosis of primary lactase deficiency, which has only recently come to the attention of the scientific community, is hypomorphic lactase variants. The role of these hypomorphic enzyme variants still has to be researched in more detail in the future. Now, when should you consider secondary lactose deficiency and what should be done about that? Well, in patients with severe symptoms or alarm symptoms and/or alarm signs, they require endoscopic evaluation and/or imaging to rule out other organic disorders. Now, alarm symptoms include age of onset of symptoms after the age of 50 years, rectal bleeding or melena, nocturnal pain or diarrhea, progressive abdominal pain, unexplained weight loss, fever, or other systemic symptoms, laboratory abnormalities like iron deficiency anemia, elevated C-reactive protein or fecal calprotectin, and a family history of inflammatory bowel disease or colorectal cancer. Now, I want to summarize what we have discussed about until this point. This summary, this first small summary, shall also serve to point out the relevance of the different terms of lactase deficiency, lactose malabsorption, and lactose intolerance. In this graph, which depicts the small intestine and the large intestine, I want to first demonstrate what happens under normal conditions when lactase activity is normal. Lactase is a membrane-bound disaccharidase which digests the disaccharide lactose into its monosaccharide components, glucose and galactose, which then are absorbed into the bloodstream. I already have told you that lactase activity can indirectly assessed by genetic tests which demonstrate genetic mutations. However, lactase activity can also be assessed by direct measurement of enzyme activity in small bowel biopsies. In this part, where the absorbed carbohydrates result in an increase in serum glucose, another older diagnostic test has a relevance. However, these serum glucose measurements, they were previously called as a lactose tolerance test. They do no longer have clinical relevance because they have a poor sensitivity and poor specificity. So what you normally should be expect is an increase in serum glucose after an oral ingestion of lactose. The lower part of the figure and the ongoing part in the column depicts what will happen to the disaccharide lactose if lactase activity is decreased or absent. The disaccharide cannot be digested. Due to its osmotic activity, it draws water into the small bowel. This may result in distension of the small bowel, and if there are additional conditions like irritable bowel syndrome or other gut-brain disorders, then symptoms due to this distension may evolve. The disaccharide, which had not been absorbed in the small bowel, arrives in the colon and there is digested by colonic bacteria into gases and short-chain fatty acids. Gases like hydrogen, methane, carbon dioxide are absorbed into the bloodstream and exhaled by the lungs, so that a breath test demonstrating the increase in hydrogen concentration after ingestion of the disaccharide demonstrates malabsorption. The results of this metabolism may, however, also result in gastrointestinal symptoms like bloating, pain, nausea, diarrhea, and flatulence. Most likely, if there are concurrent diseases, again, like IBS or inflammatory bowel disease. Now, for the assessment of these symptoms, a validated symptom questionnaire is required, and that then relates to the term of lactose intolerance. So there is a large number of contributing factors in carbohydrate intolerance. It is the carbohydrate dose, and it is additional food items which play a role. Ingested carbohydrates, which arrive in the small bowel, then are related to small intestinal factors, enzyme expression, small intestinal disease, transit time, or small intestinal bacterial overgrowth, the presence of these factors which may result in carbohydrate malabsorption. Carbohydrates reaching the colon then are fermented bacterially, so the intestinal microbiome plays a role, and the microbial function. Fermentation ultimately results in gas accumulating in the colon and water being drawn into the colon. However, to finally arrive at carbohydrate intolerance, additional factors like peripheral symptom modulation, visceral sensitivity, endocrine factors, microinflammation, barrier function, and central symptom modulation like psychiatric comorbidity, life event stress, vigilance, conditioning, nocebo effect, all of these play a role in the development of GI symptoms, finally coming to the term of carbohydrate intolerance. So it is of a huge importance to have a standardized assessment of GI symptoms after ingestion of carbohydrates in order to diagnose carbohydrate intolerance. In recent years, two very important publications summarize the indications, performance, and clinical impact of hydrogen and methane breath tests in adult and pediatric patients. This is a European guideline which was published in 2021 and gives recommendations and statements on how breath tests shall be performed, and which also suggests that for the assessment and documentation of carbohydrate intolerance, a validated questionnaire shall be used. And the validated questionnaire has been published in 2021, the Adult Carbohydrate Perception Questionnaire. With the Adult Carbohydrate Questionnaire, 5 symptoms are assessed before and after administration and ingestion of lactose. The questionnaire uses VAS scales to assess pain, nausea, bloating, flatulence, and diarrhea before and up to 3 hours after ingestion of lactose. The original version of this aCPQ is in the German and English language, and it has now been translated in validated translations into Bulgarian, Russian, Slovenian, French, Polish, Italian, Romanian, and Hungarian languages. The development of this validated symptom questionnaire now provided the opportunity to do further research on the relation between lactose malabsorption and lactose intolerance. Part of this research was published in an oral presentation at the Digestive Disease Week in May 2024. We demonstrated that there is a large discrepancy between the results of hydrogen breath tests, that is malabsorption yes or no, and the assessment of burdensome symptoms by the aCPQ, that is sensitivity yes or no, in 536 patients. Out of 226 patients who had a positive breath test, therefore they had demonstrated malabsorption, 29% had no burdensome symptoms. And out of 310 patients with a negative breath test, that is no malabsorption, 41% had burdensome symptoms. So malabsorption alone is not a sufficient explanation for the development of symptoms after ingestion of lactose, and additional factors presumably play a role in the pathogenesis of symptoms, like increased intestinal sensitivity to the malabsorbed substrate or the products of its bacterial metabolism. This recent research also helps us to understand why these older studies on the treatment of lactose intolerance did not provide definitive answers. In this review dated 2010, studies on the treatment of lactose intolerance were summarized. This was 26 randomized controlled trials on lactose-reduced or hydrolyzed milk, 2 studies on lactase supplements, 7 on probiotics, 2 on colonic adaptation, and 1 on rifaximin. The common denominator was that the level of evidence that these treatments might result in an improvement of lactose intolerance was insufficient. Why would that be? Now, there was at that time no upfront definition of and distinction between lactose malabsorption and intolerance. There were poor patient inclusion criteria. Patients were included into the studies on the basis of hydrogen breath tests, that is malabsorption. However, outcome was measured with not validated symptom assessment, so lactose intolerance. It in fact was comparison of apples and pears. There were no reproducible validated assessment criteria and no defined outcome parameters. In contrast, when patients with lactose intolerance are identified by using the aCPQ, we were able to identify patients with lactose or fructose intolerance who respond to diet. And this is clearly shown here in this graph from this paper, where the overall visual analog scale symptom scores before the diet, the black columns, and after the diet, the gray columns is shown. Patients were identified as having lactose intolerance or fructose intolerance by the aCPQ. They received instructions on a lactose or fructose reduced diet, and they returned 2 to 3 months after they had introduced their diet and re-recorded their symptoms. And symptoms with diet were compared here with symptoms before diet, and there were significant improvements of overall symptoms of lactose intolerance and of each of the individual symptoms of diarrhea, flatulence, bloating, nausea, and pain. The future of the diagnosis of carbohydrate intolerance shall move away from the paper form of the adult carbohydrate perception questionnaire, and we have transferred this aCPQ into a CE-certified medical device, an app. This is the Carboception app. This will allow home-based testing and independent from doctors' offices or outpatient clinics. It allows testing of a wide variety of sugars and carbohydrate-containing foods at different doses. It allows testing to be performed under different life conditions at home, at workplace, during vacation, during different phases of the menstrual cycle, to help understand why a patient tolerates 2 scoops of ice cream while at vacation at the sea, but not during the stressful lunch break during work. The app is currently only registered in Austria and Germany in German language. However, registrations and translations into different language is planned. So coming to the summary, lactose intolerance should be considered in patients with bloating, flatulence, nausea, diarrhea, and abdominal pain that occur with significant lactose ingestion and resolve after 5 to 7 days of avoidance of lactose-containing foods. Patients with severe symptoms or alarm symptoms require endoscopic evaluation and/or imaging to rule out other etiologies prior to evaluation for lactose intolerance. A lactose hydrogen breath test with simultaneous assessment of symptoms with a validated symptom questionnaire shall be used to confirm lactose malabsorption and intolerance. This may be useful in patients who have a low probability of being lactase non-persistent based on ethnicity. In patients with a high probability of being lactase non-persistent, the development of symptoms after ingestion of lactose may be sufficient to suspect lactose intolerance and start treatment. Symptom evaluation with a CE-certified app based on the aCPQ allows home-based diagnosis of lactose intolerance with different carbohydrate-containing foods and at different doses. With regard to management of lactose intolerance, its goal is to eliminate symptoms while maintaining calcium intake and vitamin D intake. Patients with lactose intolerance should be advised that complete elimination of dietary lactose is not required and that restriction of their intake of lactose is often sufficient to treat symptoms of lactose intolerance. Patients may use lactose-reduced products or lactase supplements. However, lactase enzyme preparations cannot completely hydrolyze all dietary lactose, and the results achieved in individual patients are variable. Current data on the effect of treatments is confounded by poor methodology of studies which were published in the past decades. Patients with inadequate dietary calcium intake may require calcium supplementation, and vitamin D levels should be monitored in patients who avoid dairy intake. And finally, the conclusions. It is of great clinical importance to distinguish between lactose malabsorption and intolerance. The adult carbohydrate perception questionnaire has been validated to diagnose lactose intolerance. Patients with lactose intolerance documented by the aCPQ benefit significantly from lactose-reduced diet, app-based diagnosis of lactose intolerance and other carbohydrate intolerances may in the future replace breath tests and paper-based aCPQ. The probability of primary lactose intolerance as a cause of nausea, bloating, flatulence, abdominal pain, or diarrhea is high in patients who have a close temporal relationship between lactose-containing food and symptoms, have an ethnic background with a high prevalence of primary lactase deficiency, and have no red flags suggestive of underlying GI diseases. Thank you for your interest in this topic of carbohydrate malabsorption. And if you are more interested in that, please follow us on Instagram. Thank you for your attention.